So we'll start with the cardiovascular system. First we will go through embryology in this video. So coming through embryology, so I would like to start embryology with the formation of the heart, then we will go with the atria and we will go with the ventricles because that would be easy step. So first the heart would be like a tube, straight tube. So this straight tube we need to modify this straight tube into a heart. So before discussing all these formations, we will go through the parts of this tube by the day 22. So this tube develops into this structure on the day 22. So this structure has a cardinal veins and a sinus horn and bulbous cordis and first aortic arch. Simply what do you need to remember is this, there will be two parts of the tube which will fuse in the center and form this two first aortic arch tubes and sinus bulbous cordis, sinus horn and a cardinal veins. As the cardinal veins fuses, you have sinus venosum and so the basic understanding is in any heart there will be two tracts, one is inflow tract and another is outflow tract. So in the heart the inflow tract is maintained by atria whereas the outflow tract is by ventricles. Okay, so as we know this is the basis of the heart. See, through the sinus venosum the blood enters to the right atrium and from the atrium to the ventricles to all your pulmonary veins or to the pulmonary arteries or the aortic trunk. So that's how the basic heart function does. So as the heart forms, you see you have atrium, you have sinus venosus, you have ventricles and you have bulbous cords and its aortic root. So the structure that we discussed here has been shown somewhat complexly over here. So concentrate now. This tube as it grows, it can't grow straight. So what happens is it just twists on itself. See, it bends on itself so that if it grows straight. So this is what we expect, but in embryology what would happen is this tube will just flex on itself. Okay, see, this is the heart tube, so it just flexes by the day 35. This atria will goes to the backward, whereas to posteriorly the ventricle will be more anterior. So as this sinus venosus and the primitive atrium grows posteriorly, the ventricle will be pushed anteriorly. See, this is the structure. Hope you understand this because this is the cardinal movement of this understanding this concept. See, again I will teach. This tube will rotates like this, which means as it grows it can't grow straight. So what will happen is this posterior portion will be rotated, will be placed posteriorly, whereas all these ventricles will be placed anteriorly. So now you have the heart, which is your rough heart. See, basically the adult heart would be like this. See, this is the adult heart. So you have this enlargement of all these ventricles and atria so that you have your final presentation of the heart by the day 50. Now let's see what structures will develop into which structure of the heart, which embryonic structure will give rise to the adult structures. So we will go from the downward. See, you have truncus arterius. The truncus arterius is nothing but the outflow tract where from does the blood goes out through your aorta and your pulmonary arteries. Aorta from the left ventricle, see, aorta from the left ventricle, whereas pulmonary from the right ventricle. So these two forms the outflow tract, and this outflow tract is from truncus arteriosus. Now let's go through some caudal structure, that is bulbous cordis. Your bulbous cord, see, atria or ventricle have two parts embryologically, so anatomically. You have a smooth part and you have a rough part. The same way your ventricle has a smooth part as well as it also has a rough part. Now coming to smooth parts, this smooth remember anywhere the primitive atria or primitive ventricle will give rise to your rough structures or the trabeculated part of your atria or else the ventricles, whereas your bulbous cordis, which is the cranial part, will give rise to the outflow tract of the ventricle. See, we are coming to this structure. See, I'll explain this aortic, which these two will are forming from the truncus arteriosus, which are your outflow tracts. See, compare this with here. Right, let me rub. Compare these structures, which are your ascending aorta and pulmonary trunk, with these structures. See, truncus arteriosus, you compare, these both are forming your outflow tract. So this pulmonary trunk and the aortic arch are forming from your, ascending aorta are forming from your truncus arteriosus. So as we go further downward, which is most caudal, you can see there are smooth parts of your right ventricle and the left ventricle. These smooth parts of the right ventricle and left ventricle are forming from bulbous cordis. You can see the truncus arteriosus and the bulbous cordis the same way. See, the bulbous cord, this is truncus arteriosus embryologically, and this will be your bulbous cordis embryologically. So these two are forming your outflow tracts. Okay, now again we will go through the primitive ventricle. What I said, anything which is primitive will give rise to the trabeculated part. So here you have trabeculated right ventricle and trabeculated left ventricle. Trabeculated is nothing but your rough parts, rough and smooth. So these rough parts are formed by primitive ventricle. So we have done our ventricles and we have done our outflow tracts. Now we will go further up and we will see how endocardial cushion develops. See, this endocardial cushion portion we will discuss in the formation of your atria and ventricles. Okay, don't worry about it. Now we will go through the atrium. What I said, anything primitive will give us a trabeculated part of right atria and right ventricle. Right atria and left atria. So here we have done with primitive atrium. Now we will go through the smooth parts. So here the smooth parts of left ventricle, smooth parts of left atria, smooth parts of right atria. See, you have sinus venosus. This is sinus venosus. It has two horns. One is right side, one is left side. So this right side of the horn will form the right ventricle's smooth part. Okay, whereas your left ventricle smooth part doesn't arise from the left horn of your sinus venosus. This is what you need to remember. The left horn of sinus venosus will give rise to coronary sinus, not to the smooth part of left atria. So this is what we need to remember. This is a trap. This pulmonary vein, what do you mean? So let's say, what is the function of pulmonary vein? Pulmonary veins brings blood from lungs to left atria. So this left atria is formed by pulmonary vein. Simple. This pulmonary veins from the smooth part of left atrium. That's it. Whereas left horn your sinus venosus will continue as coronary sinus. So these are the parts which develop. So let me conclude and give a summary, because this topic is a bit confusing. See, you have a heart tube structure like this on two sides, which fuses to form this structure by the day 22. You have bulbous cordis, you have cardinal veins and you have sinus horns. These are your first aortic arches. Okay, this is the basic structure of the heart, which is primitive structure of the primitive heart. Now as the days develop, or as the development starts, as it grows cranially and caudally, since it cannot grow more caudally, what will happen is it will twist on itself, so that all your atria and sinus venosus which are formed will be pushed backward or the posteriorly, whereas your ventricle will be pushed more towards anteriorly. So you have bulbous cordis and aortic roots. Truncus arteriosus. First we will deal with truncus arteriosus and bulbous cordis. Truncus arteriosus is nothing but we will go in the retrograde fashion of the blood flow. The blood flow from atria to the ventricles, then to the ascending aorta through the left ventricle, whereas to the pulmonary artery through the right ventricle. So we will come from backward, which is from ascending aorta and pulmonary trunk. See the blood flows like this, but we will coming from backward. See, from the backward, which has the initial portion is truncus arteriosus. So the truncus arteriosus is forming ascending aorta and pulmonary trunk. That is done. Now as we come more retrogradely, you can see you have bulbous cordis in this structure. See, in this structure you have bulbous cordis. This bulbous cordis is forming your smooth parts of right and left ventricles. Okay, so that is done. Now we will go more retrogradely. You have trabeculated parts. What we said, trabeculated is nothing but rough parts. Rough parts are formed from primitive ventricles. Okay, as we go more retrogradely, you have right atrium and left atrium. Right atrium is forming from the sinus venosus, which is smooth part, whereas left atrium is forming from pulmonary vein. Smooth part is formed from pulmonary vein, as the trabeculated parts will come from your primitive atria. So that is done. Okay, hope you see this part again so that you can understand easily. Now coming to the formation of the atria and formation of the ventricles, so that we will done with the embryology. First, see, your heart has 4 chambers, so it beats spontaneously by the week of 4. Okay, you have cardiac looping. What do you mean by cardiac looping? As we discussed, you have, left, what should be on the left side, what is left atrium, what is right atrium, or else what is the right ventricle, what is the left ventricle. All this formation, or this, you need to decide which is the right side and which is the left side. This is done by the 4 weeks, which is the left and right side polarity. Let's say you have right ventricle on the right side, left ventricle. This is the normal development. Now there is a syndrome called Carter-Jenner syndrome. What is this Carter-Jenner syndrome? You have dining arm defect. What is this dining arm? This dining arm helps in deciding which is the right side and which is the left side. Let's say you have this defect, so that what would happen is all your left side structures will be placed on the right side of your body, and all your right side structures will be placed on the left side of the body. So that what would happen is there is a rotation or a dextrocardia, which is nothing but a placement of the heart, right side on the left side on the right side. So this is nothing but a Carter-Jenner syndrome. Another thing you need to remember is, this dining arm will help in the movement of cilia. Let's say you didn't have this dining arm. What will happen? Your lungs, your trachea, your bronchi, all will have cilia. What will they help in? They help in clearance of your mucus. Well, also they will help in the defense system of your body. When this doesn't happen, you have recurrent lung infections that would happen in the patient of Carter-Jenner syndrome. Now you have separation of atria. See, development of atria is simple. Don't complicate it. See, you have right atria, which is formed as we discussed in this page. You have right atria and left atria. Okay, you have right atrium, you have left atrium. So what would happen initially is, if we go through the fetal circulation, which we will in few minutes, the right atrium will pushes its blood to the left atrium. Okay, but so there is a defect over here. See, anything defect is ostium. So this is the primary defect. We have secondary defect also, so we will call it as ostium primum, and another as ostium secundum. See, you have ostium primum. What would happen is, from the cranial part, so this is the cranial part, this is the caudal end, which is the dorsal endocardial cushion. What would happen is, there is a formation of septum. This is nothing but septum primum, which will form cranially towards the caudal side. See, septum primum grows towards the endocardial cushioning, narrowing the ostium primum, which means it tries to close the ostium primum. Then you have ostium secundum. How? See, we have closed the primary defect. See, we have closed the primary defect with, let's say this is ostium primum. We have then where would the ostium secundum would appear? This ostium secundum is nothing but this ostium primum cells aren't enough mature to live. They would die in some days. So that what would happen is, there is again formation of this ostium secundum within the ostium primum, which has formed to seal the defect of ostium primum. See, sorry. You have septum primum, you have ostium primum. See, this septum primum, what it is doing to try to do is, this septum primum tries to fill the gap of ostium primum. But what would happen, as the days passes, the septum primum cells aren't viable. So that the defect which is closed initially by septum primum isn't that great to just conceal this defect. What would happen is, then the ostium secundum would appear over here. This ostium secundum would appear in the septum primum. Okay, so to close this defect, you need to close again this defect. So that what would happen is, to the right side, which is your right atrium, this is the left atrium. To the right side of your right atrium, you have something called septum secundum, which is developing. See, you have septum secundum which is developing, trying to conceal this gap of ostium secundum. So yeah, you have septum secundum, you have let's discuss foramen now. You have septum secundum which is trying to conceal this ostium secundum. So what would happen is, it could not conceal the defect, which is, it could not cover the entire defect of your ostium secundum. It leaves some gap. This gap is nothing but your foramen ovale. This foramen ovale is important for the viability of a fetus. Why? We will discuss it in fetal circulation. So as a baby as the baby gets its birth and comes out, see, the lungs resistance would decrease. What do you mean by lung resistance would decrease? This blood over here would prefer to flow through the pulmonary artery rather than going through this foramen ovale. So that what would happen, this pressure would decrease, whereas left atrial pressure will increase drastically as the baby comes out of the mother's womb. So what would happen is, this pressure would pushes this ostium primum, and this pressure would pushes it ostium secundum so that they both fuse and the foramen oval gets closed. Okay, so I'll conclude again it. So you have first initial you have ostium primum, which is covered initially by septum primum. The septum primum is not viable. What would happen is there is a defect within the septum primum, which is nothing but your ostium secundum. To close this ostium secundum, you have nothing but septum secundum, which is developing on the right side of the right ventricle. So that as the baby comes out of the mother's womb, the lungs resistance would decrease, so that the blood in the right atrium would prefer to flow through the pulmonary artery rather than flowing through this pulmonary foramen oval. So that what would happen is this pressure would decrease and this pressure would increase, so that the septum secundum and the septum primum would just come closer, so that this defect get filled. Now let's say a baby hadn't got this defect get filled. So let's see, the failure of septum primum fusing with septum secundum after birth is seen in 25% of the population. So what would happen, this foramen oval would persist. Basically it is in a 25% of the population, but it does not manifest in all of them. See, most are asymptomatic and remains undetected. This leads to paradoxical emboli, which means the venous thrombus emboli. What are these venous thromboemboli? Let's say you have some clotting, you have DVT in the let's say in the legs, and this thrombus will pass through the venous circulation and enters the right atrium. From this right atrium, this emboli, which is thromboembolism, can enter through foramen oval and go through the left atrium and can enter the systemic circulation, which is hazardous. So this can occur in atrial septal defect. So this is the conclusion of these paras. You can go through it by pausing here. Now coming to ventricles. The development of ventricles isn't that complicated as we discussed with them. This is very simple. See, you have there we didn't set intraatrial foramen. There we said, where we used the complicated words of ostium. Here simple. You have interventricular foramen. Okay, there is articopulmonary septum rotates and fuses with the muscular ventricular septum to form membranous ventricular interseptum closing the interventricular foramen. I'll read it. Growth of endocardial cushions separate atria from the ventricles and contributes to both atrial separation, membranous portions of interventricular septum. So what are they trying to say? See, you have muscular interventricular septum, which is going, this is caudal part, this is cranial part, which is going cranially to enclose the defect between this right ventricle and the left ventricle. As it cannot completely close through entirely, so this portion should be closed by your membranous septum. From where this membranous septum, this is nothing but aorticopulmonary septum. From where this aorticopulmonary septum appears from neural crest cell. This neural crest cell will help in the formation of aorticopulmonary septum. Why the aorticopulmonary septum is rotated, not as straight line? Simple. You have right atrium, you have left atrium, right? See, I'll show you. If it is formed like this, you have something called transposition of great atria, which means from the right atria the blood would enter, instead of going through the lungs, it would enter the body, whereas through the left atrium it would enter the lungs. See, is this very dangerous condition, and it is more specific of babies of gestational diabetes mother. So yeah, if the septum is formed like this, you have a transposition of great arteries. So that what would happen is the septum would rotate itself on its axis, so that you have formation of your pulmonary atria and ascending aorta from the right and the left side of the heart respectively. So this interventricular septum muscular part has developed. So to conceal this defect, you need something called membranous interventricular septum. This membranous interventricular septum also would develop from this aortopulmonary septum. Okay, let's say you didn't have your ventricular septum, so this is nothing but ventricular septal defect. This is the most common congenital defect. This usually occurs in membranous septum. Where is this membranous septum formed? This membranous septum will form from aorticopulmonary septum. Where this from aorticopulmonary septum forms? From the neural crest cells. See, outflow formation. See, neural crest cell migration forms the truncal and bulbar ridges, the spiral and fuse to form aortopulmonary septum, and this form ascending atrium pulmonary trunk. We have already discussed. Conotruncal abnormalities. So this is one of this defect has been discussed. So let's say you have transposition of great arteries. So what do you mean? So there must be a rotation of this, this aortopulmonary septum. Let's say it hasn't rotated, so that what would you have transposition of great arteries. Now let's say this aortopulmonary septum from the neural plexus has been pushed more towards the right side. What would happen? The pulmonary trunk is not patent as it would say, so it would be more stenotic, so that you have tetralogy of great phalate. Let's say there is no formation of this aortopulmonary septum, then we would have a persistent truncus arteriosus. That's it. Now coming to valve development. What are these valves? You have valves between atria and ventricles, and between the ventricles again in the major trunks. So in what is basically seen is you need something between any two connections of the heart. So these are nothing but aortic or pulmonary and mitral tricuspid. So coming from aortic and pulmonary, they are derived from endocardial cushions of outflow tract. So these are your endocardial cushions. Okay. Mitrals are derived from fused endocardial cushions of atrioventricular canal. Sorry, atrioventricular canal. See, any valvular abnormalities can cause stenosis, regurgitant, atriatic or displaced. So we will discuss in the next video. So coming to fetal circulation. Simple. Fetal circulation is very easy. Don't get complicated. Don't try to complicate it. So there is only the lungs and liver, both else doesn't need blood. So any blood they get, they would simply stunt into the systemic circulation. Okay, this is the basics. You again, lung and liver doesn't need blood. Any blood that they would receive, they would stunt the blood into the systemic circulation. Now coming from, see, your baby receives the blood from placentas. One point to remember over here is there are two atria and there are two arteries and one vein. Left vein is left behind, which means the right vein regresses. So right vein regresses, left vein left behind, so that your left vein persists whereas the right vein disappears. So this is the basic. From the placenta you have umbilical vein. Your umbilical vein would carry oxygenated blood. Don't think the vein carries deoxygenated blood. Here this carries oxygenated blood. As the blood enters the liver, we have already discussed, your liver doesn't need blood, so that what would it do? It would simply stun the blood it receives to the systemic circulation. What is systemic circulation? You have inferior vena cava, which is nearer to it, so that what would it would form a anastomosis. Blood entering the fetus through umbilical vein is conducted via ductus venosus into IVC, bypassing hepatic circulation. See, this is what we discussed. Your liver doesn't need blood, so that what would happen? Any blood that entering to the umbilical vein will not enter the portal vein. It would enter simply into the AVC. So you have here one vein and you have here one vein. So the duct that would connect both this is nothing but ductus venosus. This ductus venosus help in circulation of the blood from the umbilical vein to the inferior vena cava. See, inferior vena cava, through the inferior vena cava the blood has entered the right atrium, and we have discussed, there is a foramen ovale. Through this foramen ovale this blood can enter the left atrium, or else it can enter the right ventricle. Okay, up to here you are clear. The blood not only enters from the inferior vena cava, you have blood coming from superior vena cava. The superior vena cava blood also could enter the right ventricle. Let's say some blood have reached the left atrium through here, and some blood have reached to the right ventricle. So as the blood passes through the, from where the right ventricle blood to enter which circulation, it would enter the pulmonary circulation. So as it enters the pulmonary circulation, you have lungs over here. These lungs are not compliant. Let's say they are hardest or not, they are hardest, but let's say they are not compliant. So they don't need blood. So they would do not allow the blood to enter into them. So this blood coming from the right ventricle to the pulmonary trunk should go somewhere. So this is coming from pulmonary artery. So where would the blood go? They would just stun their blood into the aorta. See, this is an artery. This is an artery. So this is nothing but ductus arteriosus. This ductus arteriosus connects the pulmonary artery and the arch of aorta, descending aorta. See, deoxygenated blood from through descending aorta, descending deoxygenated blood from the right atria and the right ventricle, main pulmonary artery, to the ductus arteriosus into descending aorta. So since your lungs doesn't need the blood would simply enter the aorta, and through the umbilical arteries again it would enter into the placenta where it is exchanged with the mother. So let's say the baby is born. If the baby is just born, what would happen is the lung compliance would drastically increase, so that it would allow more blood. So any blood coming from the right ventricle would easily reach here. So instead of going through the ductus arteriosus, the blood would prefer to go through the lungs, so that it would enter the lungs. Whereas here also the blood coming from the right atrium, here the pressure of left atrium would increase more drastically as the baby comes out through the mother womb. So this increased pressure pushes the septum primum through to the septum secundum, so that this foramen oval closes over here. So if this path is closed, this path is closed, the blood would easily enter into the lungs. And in the same way, here the liver now needs the blood, since it needs to purify all the breast milk and everything that baby eats or drinks. Sorry, the baby drinks, it needs to purify, so it needs some blood to enter through it. So what would happen is this ductus venosus, which we thought connecting both the umbilical vein to the inferior vena cava, this would just close over here. This defect is closed, this defect is closed, this defect is closed. Yeah. Now what would the persistence of these defects would cause? So postnatal derivatives of these defects. See, ductus arteriosus, again once again we need to remember artery, which what would it connect? It connects the pulmonary artery and the descending artery, aorta. Ligamentum arteriosum, it would transform into ligamentum arteriosum. So near the left recurrent laryngeal nerve, what does it say? It signifies, see, you have the left recurrent laryngeal nerve would be the more down, more caudal rather than right, so that it is more prone to injury. Ductus venosus forms ligamentum venosus. Foramen oval, what is foramen oval connecting? Foramen oval connecting right atrium with the left atrium. Persistent would cause fossa ovalis. Allantois would form median umbilical ligament, umbilical arteries. There are two arteries. So you have, so let's say this is the bladder. Okay, you have median umbilical ligament which is formed by allantois. These are medial umbilical, medial, medial, more lateral. So that these are formed by umbilical arteries. Umbilical will form ligamentum teres. What is ligamentum hepatum teres? See, this is what this is, here you have falciform ligament. This falciform ligament contains your ligamentum teres hepatis. Okay, so this is what we discussed over here. And say you have in NSAIDs, what do these prostaglandins do? See, prostaglandins keep the ductus arteriosus open. If you give NSAIDs, what would happen? The ductus arteriosus will close. Let's say your ductus arteriosus has been closed. Tomorrow we will discuss about anatomy and physiology of CVS. Thank you.